It's a wonderful turnout. It's an inspiration to see so many people who are thinking about how academic health centers like this one can learn about what works and doesn't for their patients and also for their populations for which they're responsible. It's a real pleasure to the Berman Institute and to the Johns Hopkins Individualized Health Initiative who are co-sponsoring this seminar. It's a real pleasure for us to see your interest. Johns Hopkins Individualized Health Initiative is a signature initiative of the university, the health system, and the applied physics laboratory that's attempting to be part of the solution to the American healthcare crisis, as well as to contribute something. And nothing is more important than the emerging complicated data. Some people call big data. Small data can be complicated too. And the question is really how to use the emerging information, the emerging data to improve patient care. And if you're trying to solve that problem, one of the first issues that arises is how to change institutions, academic health centers, into learning health centers. How can we learn to learn? And so this seminar today is really a formative step in that direction. What are the bioethical issues around consent so that we as an academic health center can learn from our patients? And I must say, it's an honor to be at Johns Hopkins, where the Berman Institute has been a leader in addressing these questions, in particular Ruth and Nancy, who have been fantastic partners with the InHealth initiative to help us contribute solutions. So we're here today to try to discuss with each other about solutions, so to learn how to learn. With no further ado, I welcome you and introduce Nancy Kass.
Well, thank you, and I imagine that most of you know that Scott Ziegler, in addition to being a remarkable biostatistician, has really been leading the way to try to transform the way Johns Hopkins thinks about how we can analyze data more efficiently, not only for these sort of lofty and general learning purposes, but really to improve clinical care in the short term. And it's a complex challenge. We're a complex health system that actually has many different systems within it. And there are a lot of people here committed to change, but there are also a lot of challenges. And we're going to focus on a particular area of that today in informed consent. So let me tell you how we're going to try to structure things today. I'm going to go through just a few slides trying to set up the problem, trying to set up a little bit more why there is some need for this thing that people are calling a learning healthcare system. And then I'm going to turn it over to our two real speakers, our two guests, Todd McNutt and David Katzelnick. So at the end of my comments, I will give you the introductions for each of them, and then we've saved a bunch of time for us to participate as a panel. You probably also saw that Dan Ford, who is the Vice Dean of Clinical Research in the School of Medicine, also had his name on the marquee, and he's going to be asking probably the first question and will be part of our panel as well, because in part of his job responsibility of overseeing the IRB office of the School of Medicine and School of Nursing, there are a lot of issues like this that he's already wrestling with. So why big data? And I want to frame this very deliberately as what's in it for patients. I think in our academic environment, we often think of it as what's in it for researchers, but I want to frame it a little more as what's in it for patients. And I have, you'll see that almost all of my slides are just giving you some quotes from two different Institute of Medicine reports that to me were transformative in their thinking about this notion of a learning healthcare system. So the Institute of Medicine, I think, was really revolutionary in naming and describing this challenge and problem we have of delivering the highest quality of care where we still have a lot to learn. Saying evidence on what's effective and under what circumstances is often lacking in clinical care, or poorly communicated to decision makers, or inadequately applied. So sometimes we don't have the evidence, sometimes people don't use the evidence. Studies of current practice patterns have consistently shown failures to deliver recommended services. There's also wide geographic variation in the intensity of services without demonstrated advantage, and sometimes more risk for the people getting the more intensive services. and waste levels that may approach a third or more of the nation's $2 trillion in healthcare expenditures. A really profound statement that, again, I think is starting to talk about, could we do better? So this idea of a need for a learning healthcare system, and bear with me, I have two more slides with quotes from the IMM, but as I was starting to summarize it, I thought I can't say it better than they already did. So many have asserted that beyond determinations of basic efficacy and safety, the dependence on the individually designed, serially constructed prospective studies, what we think of as our traditional bread and butter around here, to establish relative effectiveness and individual variation in efficacy and safety is simply impractical for most interventions. A reevaluation of how healthcare is structured to develop and apply evidence will be necessary to orient and direct IT tools toward the creation of a sustainable system that gets the right care to people when they need it, and then captures those results for improvement. The nation needs a healthcare system that learns. And I might editorialize and say learns in real time and then feeds that back. So the foundation for a learning healthcare system is continuous knowledge development, improvement, and application. Although unprecedented levels of information are available, patients and clinicians often lack access to guidance that is relevant, timely, and useful for the circumstances at hand. Overcoming this challenge will require applying computing capabilities and analytic approaches to develop real-time insights from routine patient care, disseminating knowledge using new technological tools. And this is where we get to today's seminar in part, and addressing the regulatory challenges that can inhibit progress. So why is it that informed consent becomes a challenge? I'm not going to do any kind of long rehearsing of that here, but I imagine everybody in the room knows that for really good reasons, we set up a system 40 years ago that sort of separates on purpose research from clinical care, and there's a whole infrastructure and oversight apparatus for the activities we call research, and those are absent when we call the activities or classify them as clinical care. But what if we start to create some of these tools that were talked about in the last couple of slides, where by design, data are being collected both to improve the care of patients and to use that same database, that same powerful data tool, also for learning going forward. And what is it that how is it that we can start to think about consent here? So that's it from me, and let me turn now to introducing our two speakers. Our first speaker is Dr. Todd McNutt, who is local to us here from Johns Hopkins, and really one of the leaders, I was saying earlier today, one of the poster children of InHealth because of what he has helped to develop. So Todd is an associate professor in the Division of Radiation Oncology. He's interested in the use of prior clinical patient data for improving the quality of care for new patients undergoing radiation therapy. And I want to read a little description of this tool that Todd helped to develop called OncoSpace. Johns Hopkins Radiation Oncology is moving toward the goal with a program dubbed OncoSpace, this goal of more individualized learning healthcare system. OncoSpace is a complex data warehouse that provides the precise information doctors need to create an optimal radiation treatment plan for each patient. OncoSpace is considered one of the first demonstrations of how complex patient data, information on anatomy, treatment side effects, and radiation dose distribution to specific organs can be collected from all the previously treated patients, stored in data warehouses, processed, and presented to physicians in a meaningful way so they can make treatment decisions for each patient based on that patient's unique characteristics and preferences. And I will add to that, and also to be cleared for research purposes. So Todd's going to be our first speaker. I'd like to go ahead and just tell you about our second speaker so that I don't have to jump up in the middle. Our second speaker is Dr. David Katzelnick, who has flown in from the Mayo Clinic. Thank goodness the weather cooperated. And David is the chair of the Division of Integrated Behavioral Health at the Mayo Clinic in Rochester, Minnesota. His major clinical and research interests are in mood and anxiety disorders, psychopharmacology, diagnosis and treatment of mental disorders in primary care, and medication education. He is a psychiatrist by training and also an associate professor of psychiatry. So I'm going to stop there and turn it over to Todd, and welcome. Thank you for being here.
actually a physicist, not a doctor, and that gives me the appropriate amount of naivety to take on this task. So here I'm going to talk about Oncospace and just give you an overview of it and some of our challenges and what we're trying to do. So just, in full disclosure, the work has been funded by Philips and Electa as well as Toshiba, and then some foundation funds have also been contributed to the efforts. So our problem is really in radiation therapy is that our ability to advance it is really limited by our knowledge of which individual patients are at risk of a high-grade toxicity and which patients have limited ability to cure. We tend to treat on protocol. We treat based on population-based knowledge. And really this stems from the fact that the knowledge from our clinical trials is quite coarse. We have clinical trials that give us some information, and that feeds into protocol development and treatment guidelines. It really doesn't dig down to the level of detail necessary to impact the individual patient and the individual patient's needs. So we looked at this project as an opportunity to better predict treatment outcome and provide better clinical decisions for those individual patients. So this is kind of the overview slide. We have a lot of information that goes into what we do. We have any patient history and social history, their existing performance, their diagnosis, pathology, and concurrent therapies and surgery or chemo. And then we also follow up patients and we monitor them for how well we're curing them and what toxicities they're having. And this is a lot of information that we get all the time. And our real goal is at any point during that time, we'd like to ask certain questions and use that data to help us decide how we may best treat this patient or what kind of complications might we expect further down the road so we can bring interventions earlier in the workflow. So why radiotherapy? Well, radiotherapy happens to be a very data-intensive form of medicine in the beginning. This is just a typical radiation therapy treatment plan that we do for head and neck. And you can see these lines are where the radiation dose is going, and we bring lots of beams of radiation in. And our whole goal is to conform that dose distribution to these target volumes while sparing as much as we can the normal tissues. We obviously can't spare the normal tissues too much, but we and what does this mean? This means we know where our drug goes very well in a three-dimensional format. We also know our anatomy. So these are one way that we evaluate dose. And you would just simply read this as like 50% of the parotid gland received at least 35 gray of radiation dose. So we know not only where our drug goes, but how much of it goes to what organ. So that's a lot of data that we can start working with to start showing the learning health system. The other thing we have is we have a timeline of care that's on the order of weeks to months as opposed to instantaneous like surgery. So we see a patient in consult and we have an opportunity to collect a lot of information about that patient, baseline toxicities, quality of life, diagnoses and things like that. Then we go through our simulation and treatment planning process where we learn the doses that we're about to deliver. And then once we start treating the patient, we see them weekly and we get the opportunity to capture more toxicity information, quality of life information, and any symptom management that we're intervening with. And we then, at the end of treatment, can capture final acute toxicities and things. And then we also see them in follow-up on a periodic basis depending on the service. So at any time point here, we have an opportunity to intervene with what we're doing and change what we're doing. So the timeline is a little bit more manageable than other services. And so this is the kinds of things that happen. This is just mucositis, but we score lots of other things. And we use primarily the CTCAE toxicity scoring model where you grade toxicity 0 to 5. 5 is always death. 0 is no evidence of toxicity. And this is just a sample of mucositis. And so this is in the first week of treatment, 1 to 3 weeks, 3 to 5 weeks into treatment, and then this is pretty much after treatment. And so it's towards the end of treatment. So you can see that, for the most part, most patients have very little mucositis going into treatment, and then towards the end of the treatment, it gets quite bad. But some patients are still in good shape, and we have to intervene. This affects their swallowing, their eating, things like that. So in order to collect the data in the clinical environment, the tools that we had were not very amenable to that. So we ended up building a web page, and we have a page that can be used either with iPads or on a computer. computer that allow us to collect structured data in the clinical workflow. And so several of our services have adopted a model whereby that data is collected routinely on all patients, and at the weekly visits, at the initial consult. The other thing is we have tools for assessing quality of life, so patient-reported outcomes on the iPads. We can hand the patients the iPad, they fill them out. And we also capture disease status, because that's also important. And we have some tools that sort of, at the end of the day, present an email link to the physician, and he can see all patients he's seen that day and capture the disease status of that patient. So not only do we know the toxicities, we also know how the disease is responding to the treatment and how it has responded in follow-up and if it's reoccurred down the road. So we've built a database, and this is one area of ethics, I suppose, but behind the information systems, we captured into an analytic database because we need the data formatted for aggregation and analysis to actually learn from it. And I won't go over the whole schema, but the key feature here I wanted to point out was we have a private health information table. And that table, we do need to know what patient is in the database. We can electronically transfer all of the information from our oncology information system into this without ever seeing patient information. We just tell the system, collect new data on the patients. It knows the patients, but the user doesn't, and it can go through that list of patients and do that. And it even houses a reference date, so all dates in the rest of the system are days from start of treatment, and the reference date's up here. So that table is completely locked out, nobody can see it. So when it comes to privacy, I think these are the kinds of things, we need the link, but we don't necessarily need to expose PHI. So the learning health system, this is our sort of diagram of it. So in our course of care, over time, there's a decision point. And at that decision point, we have a certain number of facts that we know about the patient. So these just things that have already happened, I suppose, or any histories. There's a few controls remaining. We may be able to change the treatment. We may be able to change the symptom management, things like that. And then there's a series of outcomes. And then there's a series of outcomes which are our measures. So we want to continue to measure. And the important thing here is, well, so what our goal is at this decision point, we'd like to use our knowledge base of data, perform some predictive modeling based on the facts and the controls of that individual patient, and present some level of prediction back to the physician and the patient so that they can use that knowledge for decision making. It can be just simple as presenting data. Perhaps it's suggestive. Right now we just want to present risk predictions, for example. And then we also want to feed that outcome back. And one of the key things here is, in order for this to work, you have to collect data on every patient, and you have to be consistent about doing that. Because if you don't, you simply don't even have the facts on the individual patient that you're trying to predict with in the first place. And you really do want this knowledge base to grow. So what can we do with the data? These are some of these things, and obviously this is an area of research, but we have things that we have done already. For example, we have what we call shape-based auto-planning, and this is a little complex, but I'll try to explain it easily. Basically, our ability to spare a critical structure from radiation in a radiation therapy treatment plan is a function of its relationship to the target volumes. And so we've characterized this spatial relationship, and in this case, between a parotid gland and a target volume. And then what we can do is, for a new patient, we can look at that shape relationship. We can go into the database and find all patients who are closer or harder to plan, and we can pull out the best dose distribution that we've ever achieved for those patients that are harder to plan, and that's now a prediction of how good a plan I can generate for the new patient. And that helps with both just quality assessment, because it tells me how good I can do, so I can try to do it. And it also, because of the way we do planning, can also feed in as an objective into that planning system, which then can automate the planning process. So we're able to, we are already, and that's in clinical use, we use it for pancreas, almost prostate, but we will. And we've used it for head and neck in the past. The other thing we're working on is weight loss prediction. In head and neck cancer, weight loss is a critical thing. If patients start losing too much weight, that's a problem. It can interrupt their care, and it can be signs of other things going on. So we have one model now where we're trying to predict weight loss 3 months post-treatment at the mid-time point of treatment to see if we can alert better to those patients that are at a higher risk of having severe weight loss so that we can intervene with feeding tubes or things like that. And that goes to the feeding tube prediction as well. So we also had a study on our feeding tube, who is the right candidate for having a prophylactic feeding tube. Some of our patients, we will put in a prophylactic feeding tube if they're at risk before they start treatment because it's much harder to put it in after they've started treatment. We're also looking at toxicity prediction. So the toxicity prediction, the idea is once a treatment plan is done, and this is the kind of models that we're working on, can we look at our dose volume histograms for the treatment plan and figure out, is this patient, based on the entire dose distribution or that full spatial dose distribution, are they at a higher risk of a high-grade toxicity than other patients so that we can start intervening there. So it's all about what can we predict in the future earlier on so we can intervene and do something new with the information. So that gets me to how we've been doing this in the consent ethics model. So I'm going to be probably controversial, maybe not, I don't know. But I feel like in this space, it's our duty to learn from every patient that we treat. And it's not just the clinician, right? It's not just the physician. There are other care providers. We have dosimetrists that do treatment planning. They need to learn, right? Our system, the people in the clinic need to learn. And they have to have the ability to do that. And we all do that now through just our experience. But why not, do it electronically as well? We should be able to capture that and provide that experience back. And given that we have the ability to do that, we should. I think quantifying this patient experience provides much easier recall and enhances and enables the sharing of that experience. These models will help newcoming practicing clinicians gain from the experience of people before them, and we should take advantage of that. And then, if we're capturing data on every patient the same way, then isn't that standard of care? I mean, at that point, nobody's being treated one way or another. So is that standard of care? I think it is. I'm not sure. So it's the question, are we doing research or are we doing quality management at this point? And maybe the people in this room can answer that question. and when does it become research? We've all heard it becomes research when there's an intent to publish. Well, there's a global intent to publish if we find something new, but is it intent to publish if we're trying to capture it and build a learning health system? There's very gray. So I think when a group of patients is separated from another group for reasons of learning from it, perhaps that's when it becomes research. So how are we currently doing it? Well, we're doing it differently depending on which service we are dealing with. On the prostate service, we do have a broad research database consent that we give to all patients, so they consent to having their data collected into a research database. So we're sort of piggybacking on that. In head and neck, we have 2 attending physicians, and the clinical workflow has become data-driven, so they're actually looking at the data, right? They're monitoring the data about these patients in their normal clinical care. So, and this data is captured the same way on all patients. And we do analyze the data to evaluate clinical quality to some extent. And when we do have a research question or an intent to publish, we submitted an IRB for retrospective review. It's usually expedited, and we actually have one for data mining on it. A little bit of a blanket IRB, but we're trying our best to do that right. On the pancreas service, we have a research database consent, but only for the multidisciplinary care patients. They have more data collected on them than on regular service patients, so it's a little bit different. But then we treat the other pancreas patients as standard care. So there's my knowledge. So I open more questions up. I hope everybody's okay with that, and I hope I didn't go over my time.
So we'll have David, and then we'll come up with for everybody.
Thank you, and thanks everybody for inviting me to Johns Hopkins. It's really an honor to be here. It's much more tropical than Minnesota right now. I'm originally from Bethesda, so it's nice being back in Maryland. Partly, I'm certainly not an literature originally was doing randomized controlled trials in large health systems. And I, over time, got very frustrated that we would do things that showed that one intervention was much better than another. Often, when you were lucky, you'd get them published in good journals, and you would wait, and nothing would happen. In fact, we did studies showing that the place that we originally did them didn't even keep doing them after the study left. And so I then evolved to the point of realizing there's all these effective treatments that are out there that are not available to our patients, and trying to understand how do you get from an effectiveness trial to actually providing it in quite diverse settings. And so that's what we've been doing. First of all, disclosure. I'm an employee of Mayo Clinic, have funding through the grant from the CMMI grant and from the National Network of Depression Centers, which I'll say a little bit about with the MORE project, and have ownership of shares in healthcare technology systems, which I think doesn't have anything to do with this. So 2 things today. First is describing the COMPASS grant, which was a large CMMI grant that was in the first round, which is going to be completed in July. And then the second, talking about the National Network of Depression Centers MORE project, which Dr. Kass was originally advising us, giving us an idea, and talked me into coming to talk about it. So in terms of change, we're ready to begin the next phase of keeping things exactly the way they are. And there's clearly inertia to making things be different, and change is something which is hard, and so you really need to make changes when it's important, and hopefully talking today about why it is important to make changes. So I'm going to start by talking about COMPASS, the care of mental, physical, and substance use symptoms. This is the slide that CMS requires that I put in, which more or less says that this is my opinion and not the opinion of CMS or anybody else. So what exactly is COMPASS? It's a 3-year grant from CMS, a large grant of, I think, $17 million. There was a study that was done called Team Care that was done through Group Health at University of Washington that showed that you can not only improve outcomes, but actually save money by treating people who had a combination of depression plus diabetes or depression and cardiovascular disease. And the idea of this was to say, in primary care settings, and the idea was, is this something that actually can be disseminated on a wide scale that CMS would hopefully reimburse if it makes sense and works like it did in the original effectiveness trial. These are some of the organizations that participated, and I put this up here mainly because you'll see that there's huge variability. That the study was originally done in Group Health, which is probably sort of like Kaiser, but there were organizations, the group in Massachusetts are a bunch of small, separate primary care clinics that are very different from Kaiser, and Mayo is different. And so that the idea is, how do you adapt something like this so you don't lose the key parts of it, but make it work in different settings? And does that work? Just give you the idea. The idea is that patients need to be clinically depressed and not only have diabetes or heart disease, but have lab symptoms that are indicative that they're not under good control. So you're looking at people where there's a sense that there's something that can be done. And the idea here was that if people just had the medical illness, that's something that probably could be controlled in primary care. If they just had the mental illness, that could, but both together was very difficult. And they tend to be a population who don't do well in routine practice, and there's an opportunity to help people where they've given up, practice has given up, and to be able to help them get better. So the data that we're collecting as part of that, the main part of it is to help patients and to help their providers take better care of them. The clinics that are involved in doing COMPASS, this is their standard of care. Everybody who comes in who meets these criteria gets COMPASS care, assuming they're willing to cooperate with doing that. And the idea is that there's very strong data that this really does work, that it helps, but it costs more money. So that the idea of having clinics be talked into giving it to everybody is very straightforward. The second part of it is the multi-center part of it in terms of the database is to first compare whether the outcomes look like they did from the large effectiveness trial, and then I'll say a little bit about the survey that was done as well, which is looking at utilization data. Now this right here, you don't need to look at it in too much detail, but the point of this is that right here is the 12-month data from the randomized trial that was in New England Journal, and to the right are the data that we have from Mayo so far, looking at outcomes for depression, diabetes, lipids, and so forth, and seeing that at 12 months, the outcomes that we've seen on the first 312 patients look very much like the data from the original trial. It is interesting, just as an aside, that at 6 months, they don't look as good. So in the real world, you get a voltage drop in the short term, but eventually they catch up and you get the same outcomes. It just takes longer. And you'll see just in a second that the data that we have individually gets de-identified and sent centrally with the idea of looking at a number of different things in terms of overall as a group, are we improving patients in the way that we hope? And this diagram, not quite as complicated as some of yours, Todd, but we're working on it, is that right here in the middle under Mayo, as an example, is the quality improvement process where we're taking care of people who, the care coordinators working with the psychiatrists and primary care providers are taking care of people. Every patient ends up being in the clinical registry. The registry actually sits over here at the Ames Center at the University of Washington, and there's a business use agreement and HIPAA and so forth in terms of the data that's going into the registry. Each week, a separate research administrator pulls the data, and everybody but the people who have the Minnesota research authorization. In Minnesota, people can choose that if they don't want their data used as part of research, even if it's de-identified, they can choose that. And they can opt out of that happening. So we take all those people and took them out of this, and everybody who's left, their de-identified data goes to the central registry, which gets put in with the rest of the de-identified registry from the other 15 sites. There's a separate thing where people are, if they choose to, can do a survey that Health Partners Institute does here, where they do a release of information to give their name and contact information so that the research survey team can call them. If they choose that they don't want to do the survey, that's fine, they don't do it, and they just get taken care of like everybody else. Now, the way that this has worked, and I think part of the reason I'm here is talking about how the consent worked with this. So all the IRBs reviewed this, including Mayo's, which has very, from my perspective, relatively conservative IRB in terms of doing these things, and all of them determined that it was reasonable to waive the written informed consent for the patients who are being taken care of because of multiple reasons, the de-identified data and the fact that it was very low risk, and it was really not feasible to have non-research people all over the place at all these clinics be doing informed consent in a way that they weren't trained to be able to do. So it wasn't really possible to do it that way. And for that, as I mentioned, for the people who did the authorization or release, they could decline that. So that was the first part. The second thing I want to talk about is the MORE program, and Dr. Peter Zandi and I are working on that with the National Network of Depression Centers, which are 21 mainly universities around the country that are prominent in terms of doing mental health research. So Johns Hopkins, Mayo Clinic, Mass General, Duke, places like that are all involved in doing this. And the idea is partly to work together to find ways of taking better care of people who have mood disorders. And so part of it was to not each individually be looking at ways of helping our patients, but to be able to synergistically work together to be able to do that. So this MORE program has two main objectives. The first is to promote measurement-based care. That in mental health, there's been a tendency of people come in, they have depression, the provider says, how are you feeling? And they say, oh, I'm doing better. Great, good. And there's like no systematic measurement. That all of the FDA trials are done with measures, but when you actually in care, you tend to not get measures. And there's actually a way of systematically collecting patient-rated outcomes where you can do that in a way that really does help. And the main core of this is that it is helpful for providers and for patients on a clinical basis right at the point of care in terms of helping provide better care so that they're more likely to get better. And the second part of it is creating a platform to provide quality improvement at a clinical and population level. This is a sort of a schematic of this. In the beginning, it mainly will have the patient here doing the patient-rated outcomes into the portal, going into the registry, and then for the clinician dashboard, the clinician being able to get the information back real time, right away afterwards, to see how people are doing in terms of making decisions for treatment. And eventually, over time, we're hoping to be able to pull treatment data as well from the EMR. So the idea is, and I won't go through this in great detail, a patient comes in who has depression. They go in and the person at the desk gives them a computer, laptop. They go in and they register and answer questions related to how they're doing for depression, anxiety, and other quality of life measures. And then that instantly goes into the system, and when they walk into the provider's office, they turn it on and they have a clinician dashboard that shows how they're doing. There will be various different things, including sensitive things with it in terms of including suicidality and whether there's a concern that they might be suicidal. And so you get a dashboard here that looks like this. And then the second part of it is a research part, which is that the data is de-identified into a separate research database that then, with controls and being a very strong firewall from the identified information, that we can look in aggregate at patients with what works. Does certain medications, different patterns of medicines for patients work or not work? Most of the research that's been done in mental health has been done with tens or hundreds of patients. There's a few studies that have 1,000, 1,500. The goal of this is to have tens of thousands, maybe hundreds of thousands of people being able to participate and to learn on a large scale on really how to take better care of people with mood disorders. This is a quick schematic showing a separation from the protected schema and the de-identified. And we're collecting, as I mentioned, the patient-rated outcomes, and we'll get additional information on treatment. Now the last part, which I think will be where there's the most discussion about this, and I'll need help maybe from Nancy with this, who's not an expert, is what kind of consent do you need or don't need for this kind of a program. I think everybody can see that there's values of this, of weighing the pros and cons in terms of the consent process. And the current proposal now is for it to be exempt from human subjects research, which eliminates the requirement for signed informed consent. The basis for that being that the data being collected is being used clinically, and that's the primary purpose for it, and that the research data will all be de-identified, and there's a system of systematically separating it with an honest broker. We're still working on the question of whether it's truly non-human subjects or whether conceivably you would need to have a waiver of informed consent like we did in the Compass study. And there's been a strong decision, and some of this was really from a patient advocate who was with the group, that we make sure that regardless of whether there's a consent process or not, that we notify and let everybody know what will be happening with the data, and give them the potential to be able to have their data be opted, for them to opt out of it being used for research, so that they're just being taken care of like everybody else. But if they decide, sort of like the Minnesota Research Agreement, they don't want their data being aggregated, that they can choose to do that. And that's it.
Great.
So,
So maybe I can invite the panelists, David, don't go too far, to come sit up here. And Dan, do you want to, I don't know if you want to start us off with a question or a thought, and then we're going to open it up to everyone else. It's great, we have almost 25 minutes for discussion.
Well, as you can see, this is, why is this a new world? Why are these projects different than we had 20 or 30 years ago? Certainly the flow of information and the ability to have information move around from inside the health system to outside, to have multiple people work with the data is something that we haven't seen before, right? This could be whether it was the clinician that was really working directly with that patient and only had that obligation to the patient. It could be somebody that was in charge of the clinic or the quality improvement for the health system. And then obviously it could be the researcher, somebody outside of that institution that for the first time had access to the data. So I think that's where we are looking at this in a different way of how to protect the patients in light of this new ability to use data. And some of these are hypothetical risks because we're not really sure versus what we know are some real risk. Part of it is how much should the patients know about this, what's practicable in terms of getting consent and informing. And then we have the regulatory framework, which frankly, I do think most IRBs in health systems are able, there are exceptions in most of these that allow us to make decisions that are not nearly as sort of ironclad as you might expect. So I thought maybe we would just start off by, if there was no regulatory framework, and you are in charge of protecting the patients that have trusted you to be American. What do you worry about? And I will point out the other one just to think a little bit about, because we're getting examples of this where it's the use of data, and I'll just give you the example just to think about it a little bit. So Biogen, which is the largest company that makes multiple sclerosis medications, has approached us because they want to become the healthcare learning system for multiple sclerosis care in America. So in that case, do we waive consent? I mean, is that an issue for patients?
It's a great question. I think that without the regulatory things, that is critical in the work that I do with mental health, that there's still significant stigma for having mental illness, and so having release of information is at least as big a deal, if not more of a big deal. And certainly even substance abuse has its separate categories in terms of how it's looked at, and so that we really want to be extremely careful to make sure to not release people's information inappropriately, both because it would be a terrible thing, and if it happened, then it would shut down doing all this kind of research for all kinds of projects. And so we try to bend over backwards to be extremely careful and create extra levels of security to make sure that that doesn't happen. The other thing that we're being careful of, that I think is important, is collecting data which is important on an individual basis that doesn't get acted on. So that if we're collecting information about someone that puts them at significant risk of suicidality, that we make sure that there's a process that isn't missed or lost as part of collecting the data, and that we make sure that the providers that are using it understand how to use it well and have safety from that perspective. And from my end, I think as much as possible to let people understand and know what's going on as part of this so that they can make good decisions is key.
So, I guess I'll add a little bit. Ours is a little bit different in that ours is mostly local within our health system, within our internet network. But I will say that I think one of the troubles is standardizing what PHI is and what it means to protect it, right? I'm not sure if it's the PHI that's really the risk, right? I mean, because if you can't link it to the patient, then you probably are pretty safe, right? So I think standards by which we do that and institutional policies that tell us how to do that and how to do that right under the right guidelines are going to be very key.
So Todd, just know that because PHI has its limits and definition, just tell me, for your imaging data, how identifiable is that in terms of seeing some of those models?
We do not store imaging data. We only store shapes, so the internal and anatomical shapes.
So how identifiable is that?
I think quite hard. I mean, unless you know what somebody's bladder looks like. I mean, I suppose in one area of the head and neck, we know where the eyes are, but we don't know where the nose or mouth, or we know where the inner ear is. But I don't even know if facial recognition kind of software can expect with that.
All right, let's open it up. Deborah.
Okay, so especially for the oncology case, what about genetic data? Because genetic data arguably is not de-identifiable. So,
At this point, we don't have any genetic data. We have great visions. But yeah, no, I totally understand that. And that's why I think we need this discussion. So I think what we're doing is a good thing. I think we need to do this in advanced healthcare. And we need folks like yourselves to give us the guidance. We can't be experts in this area. Not every researcher can be expert in this. We need the guidance from our institution to tell us how to do it.
So, this is for Dan, actually. I'm not sure you even need to answer, Dan, because what I've thought about, what are we protecting patients from? When you say, because you use the generic word, we need to protect patients. Protect them from what exactly? Just so we're all clear, because if that's not well defined, then I don't know how we set up a system to protect them. And that issue has not been particularly clear to many of us who've done clinical research, particularly over the last few years where these issues have become considerably less obvious to me. So that's the first question, then I'll have a follow-up.
Well, I mean, I think the way we talk about it is sort of misuse of their data, and that can be in multiple ways, right? It could be the data which, when they go into the office, they're anticipating that it's a relationship between them and their doctor, and they know that, I think part of it, we know that there's something that the patients understand there's a broader look at quality improvement, and who might look at it, but I don't believe, for example, that patients believe their data should be used necessarily for whatever that concept of marketing or getting directly or helping a drug company set the price of their drug, right? So I think that's where you begin to say, that wasn't really what I thought, and I believe I should have a choice on how the data is used in that way. I think some of it, a little bit on the, are there any risks? I do think sort of this issue about the data flow could be, right? They anticipate that, that their doctor at that visit is looking at all the data that they've been asked about, right? They don't know, because it's not very clear when they're filling out a questionnaire or whatever, whether that data is being looked at in, instantaneously, in an hour, in 30 days, or once a year. And so I think that is just making sure that everybody knows who sees the data and when is also important. But as there's more and more ways to get data from patients to their providers. And sometimes, from research, we change that flow.
So my follow-up, because I thought you'd answer it that way, which is not incorrect, of course, which is you gave a couple examples of something that I wouldn't say necessarily extreme, but certainly on some fringe, for example, letting a company have access to information to set some marketing value of some drug. I would suggest that's further on the spectrum. But where are the boundaries? Who sets the boundaries? Because needless to say, depending on which IRB at Johns Hopkins, I'm not sure they're always the same. So who owns that responsibility? Does the institution own it? Does something as broad as the IOM own it? Where does that sit?
Well, in my view, so the IRB is not just for Johns Hopkins, School of Medicine, School of Nursing, but it is for Johns Hopkins Health System. And so, to a large extent, we are also, trying to take into consideration the interests of Johns Hopkins Health System. And we work, I see down Jennifer, we try to work with the health system on what we see as any risk related to HIPAA or other regulations. But I think a lot of it still is engaging more with the patients. And I will say, I still believe if you said to a patient, show me the Johns Hopkins policy on how your data is being used, we would have a hard time pointing to that policy, as would most health systems. And I think that's that's where the problems begin. I can only give you sort of the extremes, but I will point out, I mentioned this to Todd a little bit. The other one about what's quality improvement and what is research that I don't think we should ignore is what is the cost to patients. And I'll put it this way, like, how long do you follow up those patients? And is it quality improvement or is it research? And we've certainly had some patients say, why am I keep being asked to come back to this clinic? It's been 10 years, I do not have any more cancer recurrence, and I keep coming back. And of course, it's not free, right? They're being charged for the lab test. They're being charged for the visit. And, I think this notion of quality improvement and research, that's another one that we shouldn't forget about.
And I can just chime something again, because it's a great question. There's the practical answer to your question of who decides for your project here at Johns Hopkins. And that is going to be some IRB here. But there's this broader conceptual question that I think we're all struggling with, which is where ought those lines be drawn? And we have been trained, I think, for really good reason to think of, to frame our questions the way you framed your first question, which is what are the things we're worried about? What are all the things that can go wrong when we collect data from people? And it's really important to think about that. What I think we've had less, what we've done on a less routine basis are what are all the things that can go wrong because we don't collect the data. And ethics is all about balancing. The things that are just one-sided are fairly easy. But when we have this tension between here are the good things that can happen when we collect data and here are the things we have to worry about, that's where I think things get interesting and important, and we start to weigh and feel things, and to some degree, we, from the academic world, have to be held accountable that all these great lofty promises we're making are really going to happen. And we have to be able to do follow-up 2 years later that says clinical care was changed as a result of this data. And if that's all a farce, then that's really relevant to what we do going forward after that. Yes, Scott.
I want to ask you to answer an ethical question. Imagine that Todd's system has the capacity to identify, based upon the plan of radiation treatment, how to reduce the risk of aspiration of life-threatening condition by to a half of what it was. Suppose his quality assurance determines that that is possible. Is he ethically, is actually radiation oncology and Johns Hopkins ethically bound to use that system for each patient? That is to say, is it okay if they choose not to use it, it's expensive, it requires data collection, etc.? Is there there's an ethical consequence to the risk of data being misallocated someplace or someone seeing data, but is there an ethical risk to not using data in a way where had you used it, it would have saved lives?
Well, so, the easy answer is of course. It would be even more straightforward if we had a remotely rational healthcare system that provided everybody the care that they needed. You're also, if we bracket the context in which so many people are not getting all sorts of really normal things that are not in situations like head and neck cancer, that we know work, and they're not getting them. But presumably in any situation, right? If you're a healthcare provider or institution and there's a patient, and theoretically there should always be doing the best thing you can. I think that's sort of related to this previous conversation a minute ago, which is what are the upsides of collecting all of this data, and can there be pretty consequential differences that you can make in the course of an individual patient?
And does the problem change if we collect the data versus if we don't collect it? Obviously, I mean, we're here because we're collecting all this information. The question is, should we be looking at it?
I think I don't understand the question, because what would you be doing if you collected the data and didn't look at it?
That's what we're doing now.
Right, so in other words, is there a moral obligation to collect data and learn from it? Well, I mean, you're preaching to the choir here, so, I'm going to call that, for me, I mean, yes, this is something, no joke to people who know me, this is something I have very strong feelings about, and I think that there's a moral duty of the healthcare system. I mean, we now, doctors and nurses do the best they can, as Todd was saying, I think based on their experience, and sometimes by calling a trusted colleague, so now you have the experience of two good brains. If that obviously can be translated into, we're going to learn everything from all the people who've had this kind of head and neck cancer at Johns Hopkins, not to mention 5 other institutions. I mean, of course that's more powerful. And it seems to me, and this is true for so many ethics challenges that I and all my ethics colleagues have faced, it's like, okay, so we have to be clear on what the goals are. And I'll go back to what I said a minute ago. The goal is not only to protect information, the goal is to improve healthcare quality while keeping everything safe for patients. And it's like, okay, we've got these simultaneous joint goals. We've got a lot of smart people. Let's solve this. And I would argue that we've solved more complex problems than that. And no solution is perfect, but every time you come up with a solution, you have to think about what the upsides and downsides are of that compared to an alternative solution. And not saying anything this crowd doesn't know. Yes, Ted.
Yeah, hey, I was going to ask, I'm going to give 2 caveats up front and then ask the question. The first is just that Hopkins and Mayo, both of them are not only subject to HIPAA, but also to state-specific medical privacy laws. And the second one is that even if something's legally permissible, there may be decisive ethical reasons not to take a certain legally permissible alternative. So I was going to go back to the first way you framed it, which is imagine there's no regulatory framework. And actually, given some of the regulatory history, can some of that actually provide maybe an initial pathway? And I was just going to focus on HIPAA itself, and HIPAA's exceptions in 164.512. One of the exceptions, is the research exception. And this is an exception where uses and disclosures of PHI can be done without authorization, without opportunity to even challenge it by the individual. One of the organs that's in there, and I think the arguments for the learning healthcare system are pretty strong, but there seems to be this notion that there's an organ called the privacy board that's an alternative to the IRB. And I'm curious, in the Hopkins experience and the Mayo experience, whether there has been experience with developing such a separate non-IRB board to decide these kinds of questions, or whether there's thought to the utility of that as enabling the kinds of considerations that come out of the learning healthcare work.
Well, I think most institutions combine the privacy board and the IRB. And I think what I actually think we don't do enough of is we focus so much on the initial decision about getting access. And if you ask most places, Hopkins included, so do you do a follow-up to find out if the data stayed where it stayed, where they said it was going to stay, that they used it for the data, for the questions they thought? I would say we don't do that routinely. And so could there be an entity that always says the great thing on the application on the privacy, and it's going to help generate new knowledge and that, but in fact what it really does is it's just kind of descriptive, and that data sits on a server and just has risk for being found, and you don't really get anything good for it. I think it's there, and that's where I would think if any board was going to do a better job, it wouldn't be so much on the initial application. It would be more on the follow-through.
We can probably do one more question. Yeah, Jennifer.
Just wanted to point out we do have a data governance initiative in the health system, and we are trying to take some of this out of the purview of the IRB and look at those back-end issues. And assuming the IRB has validated the use, what are the security requirements that we want to have, and what is the auditing? So I think that's the direction that a lot of this will go.
And one other thing is we have a large enterprise-wide EMR that carries all kinds of private health information in it. And I would argue that its discoverability with the number of users and passwords and things like that that are out there is probably much bigger than the discoverability of our analytic database that's behind the scenes that actually locks out the PHI cables. So I think you have to really balance that and make sure that, yes, we would definitely adhere to any, protection any protective guidelines that are given to us, and we love the audited on that. But at the same time, we have to be rational with the current entire unit.
The other thing which is related to that in terms of what you're talking about with the health system is that right now, at least where I am, I guess is Baltimore too, that the health system changes are happening incredibly fast. And decisions get made whether you have research or not, and they have to be made one way or the other. And by setting up systems that are consistently collecting information so that when those decisions have to be made, you have some reasonable way of doing it, that if you decide, okay, well, we're only going to make decisions based on large randomized trials, which are going to take 4 or 5 years, that right now it's hard to actually know what you would make sense to do with a randomized trials that take 5 years from a health service perspective. So setting up structures that allow you to collect the information to begin with is really important because of the time crunch that we're in.
Okay, I think we probably have to end at this point, but let's thank our speakers and a special thank you all for the